All right, imagine this scenario. Your patient is just completely wiped out, incredibly thirsty, and producing a frankly unbelievable amount of urine. We're talking 15, maybe even 20 liters every single day. Now, that's not just an inconvenience, it's a massive, massive disruption to the body's finely tuned water balance. So when you're faced with this kind of extreme polyuria, where do you even begin to unravel this mystery? Well, welcome. Today, we're going to crack the code on this exact problem of extreme thirst and urination. We're going to walk through this really elegant diagnostic pathway that clinicians use to solve the puzzle, a pathway often called the thirst test. Okay, so the very first clue is right there in the name of the condition we're looking at, diabetes insipidus. You know, insipid just means tasteless or dilute. This immediately sets it apart from the diabetes you probably know, diabetes mellitus, where mellitus means honey sweet because there's sugar in the urine. So right away, we know our problem isn't about sugar at all. It's a pure disorder of water balance. To solve any case, you've got to identify your main suspects, right? And here, there are 3 primary conditions that can cause this massive flood of dilute urine. So let's meet them. First up, we have primary polydipsia. Now, in this case, the underlying hormone system that manages water balance is actually working perfectly. The problem is happening before that. The patient is simply drinking way too much water, maybe because of a psychiatric condition or just a faulty thirst signal. The body's just desperately trying to get rid of all the extra fluid it's being given. Our second suspect is central diabetes insipidus, or CDI. Now here, the problem starts in the brain. The posterior pituitary gland just fails to make and send out enough of this really critical hormone called antidiuretic hormone, or ADH. You might also know it as vasopressin. Without that hormone telling the kidneys to conserve water, everything just flows right out. And our last suspect on the list, nephrogenic diabetes insipidus, or NDI. So in this situation, the brain is doing its job perfectly. It's sending out ADH just like it's supposed to. The problem is at the destination, the kidneys. They're resistant to the hormone signal, usually because of a defect in the very receptors that are supposed to get the message. So to kind of sum these 3 up, we can use some simple analogies. For primary polydipsia, you can think of it like the water main is just broken. There's way too much water coming into the system. With central DI, the message from the brain to save water was never even sent. And for nephrogenic DI, the message was sent, but the receiver in the kidneys is completely turned off. All right, we've got our suspects lined up. So how do we tell them apart? Let's move on to step 1 of our investigation, the water deprivation test, also known as the dehydration test. You know, the logic here is actually pretty simple, but it's powerful. We carefully stop all fluids and monitor the patient really closely. We're essentially waiting to see if the body can respond to this stress of dehydration. Of course, we watch things like weight and blood pressure for safety, but the key thing we're looking at is urine osmolality, basically how concentrated the urine gets. We keep this going until the serum sodium starts to rise, which is a crystal clear sign of dehydration. Okay, here's our first little clinical quiz for you. After hours of this test, your patient's body has had every single reason to conserve water, but their urine is still super dilute, with an osmolarity way below 300. So what does that result immediately tell you about our list of suspects? And the answer is we can totally rule out primary polydipsia. See, a person with primary polydipsia has a normal hormone system. When you take away their water, their brain should release ADH, and their kidneys should respond by concentrating the urine. The fact that the urine stays dilute proves the system is broken. The patient definitely has some form of diabetes insipidus. Awesome. We've just eliminated one suspect from our lineup. The patient has diabetes insipidus for sure, but now we're staring down the final question. Is the problem central, meaning the brain isn't sending the signal, or is it nephrogenic, meaning the kidneys aren't listening to it? And this brings us right to the final step in our diagnostic journey, the DDAVP challenge. This is where we get our definitive answer. So what exactly is DDAVP? Well, it's desmopressin, which is just a synthetic, lab-made version of that ADH hormone. By giving this to the patient, we're basically handing them that conserve water message directly. And this sets up our final test. Will the kidneys finally listen now that they've been given this signal loud and clear? All right, time for our final quiz. After we give the DDAVP, there are really only 2 possible outcomes. In scenario A, the urine becomes way more concentrated. The osmolality shoots up by over 50%. In scenario B, almost nothing happens. The urine just stays dilute. So have a look. Which diagnosis matches which scenario? It's time for the big reveal.
Let's solve this diagnosis once and for all.
If you picked scenario A for central DI, you are absolutely right. But let's talk about why. See, in central DII, the kidneys were never the problem. They were perfectly healthy, just sitting there waiting for a signal that the brain wasn't sending. By giving DDAVP, we just provided that missing signal, and boom, the kidneys immediately responded. And this is so important because it means the treatment is pretty straightforward. You just have to replace the missing hormone.
And that means, of course, that scenario B, where the urine failed to concentrate at all, is our diagnosis for nephrogenic diabetes insipidus. This gets right to the heart of the problem in NDI. The kidneys themselves are resistant to ADH, and that's typically because the V2 receptors that are supposed to grab onto the hormone are faulty. You can send all the messages you want, natural or synthetic, but if the receiver is broken, nothing is going to happen. The message arrives, but nobody's home to answer. And this is why the diagnosis is so critical. Giving more hormone is useless. The treatment has to focus on the kidneys themselves.
So there we have it. We've solved our case. Let's just take a quick step back and appreciate this whole pathway, because understanding how we got the answer tells us exactly what we need to do next. Here it is, all laid out. We started with a patient making tons of dilute urine. When their urine failed to concentrate after water deprivation, that confirmed diabetes insipidus and ruled out primary polydipsia. Then, the response to synthetic ADH was the final piece of the puzzle. A strong response means the problem was central. No response means the problem was nephrogenic. It's really a beautiful piece of diagnostic logic when you think about it. So we've cracked the code for when the ADH signal fails or when the kidneys can't even hear it. But that leaves one final really fascinating question. What happens in those rare cases where the problem isn't the hormone or the kidney, but the actual osmoreceptors in the brain, the very sensors that are supposed to detect dehydration and make you feel thirsty in the first place? What happens when that fundamental sensor is broken? Well, that's a story for another time.